Hello, my name is Yejun Hong. I'm a medical student at the University of Calgary, and our team is here to explain diabetic retinopathy. Diabetic retinopathy is one of the major connections between ophthalmology and endocrinology. Roughly 7.3% of Canadians whose age is 12 or older has diabetes. This is roughly 2.3 million people, and therefore diabetes is one of the most common reason patients visit the endocrinology clinic. Diabetic retinopathy is a very well-known complication of diabetes mellitus, and perhaps due to the sheer number of diabetic patients, this is the most common cause of blindness in populations between the age of 20 to 65. To provide a little preview of our entire presentation, diabetes, in a very simplified statement, is a sustained high level of glucose in the bloodstream. This constant hyperglycemia can cause damage to the retinal vasculature and therefore the retina, because a lot of things will leak from the damaged blood vessels. Characteristic patterns of hemorrhages, such as the dot blot hemorrhages within the retina, microaneurysm of the microvasculature, and retinal edema from leakage and ischemia of downstream tissues from the leakage can occur. Neovascularization and macular edema can be complications down the road if hyperglycemia is not under control. Retinal detachment, venous beating patterns, and intraretinal microvascular abnormalities are also observed in diabetic retinopathy patients. So what exactly is diabetes? The full name for diabetes is diabetes mellitus. This is to distinguish the disease from diabetes insipidus, which is related to abnormal levels of fluid and sodium in the body. And there are two types of diabetes mellitus. Type 1, also known as insulin-dependent diabetes mellitus, is when the insulin producing cells in the pancreas are directly destroyed. So the immune system of the body attacks the beta cells of the pancreas. So there is less insulin responding to the level of glucose in the bloodstream. Insulin acts as sort of a molecular funnel attaching at the insulin receptor of the cells and allowing entrance of glucose molecules into the cells. Therefore, lack of insulin raises the glucose level in the blood, and in turn, cells will be deprived of nutrients. Type 2 diabetes mellitus is essentially the resistance of such insulin receptors to insulin. The pancreatic beta cells are okay, at least at first. The increasing insulin resistance across the body means that although the level of insulin is adequate for someone who has eaten something, these insulin are useless because they can't bind properly to the body cells, and therefore glucose cannot properly enter the cells. This is a unique and rare occasion where the hormones are intact, but the receptors across the body is impaired. This is known as insulin resistance, and sensing the constant constantly high level of glucose in the bloodstream, the pancreatic beta cells are stimulated to gradually work harder and harder. But compared to their efforts, the glucose levels will remain high in the bloodstream. Eventually, they reach the peak limit of their function, and eventually even the pancreatic beta cells eventually fail due to overwork. Type 2 diabetes is known as insulin-independent diabetes, but upon failure of the pancreatic beta cells, it too becomes insulin-dependent. Having a constantly high level of glucose in the blood can alter the osmolarity and viscosity in the blood, as well as oxidative stress. Also, because the primary fuel source cannot be absorbed, the body turns to an alternative source of fuel, lipids. In the process of breaking down lipids and producing acidic ketone bodies, the body inevitably enters a further state of deterioration. So, with type 2 diabetes, glucotoxicity is combined with lipotoxicity. The state of the patients in terms of diabetes is mainly determined through blood glucose levels. Take a look at the below criteria. This is overly simplified, but mainly fasting blood glucose, or the level of glucose in the blood after not eating for around 2 hours, needs to be above 7 to determine someone to have diabetes. And A1C is another important measurement as well. A1C is a measure of the degree of glycosylation of hemoglobin. Hemoglobin is a major component of red blood cells, compacted within the cell to carry oxygen molecules around and supply them to the cells all over the body. With very high level of glucose, more of the glucose molecules are likely to stick randomly to a hemoglobin molecule. Ideally, that level can be maintained under 6.5. Oral glucose tolerance test is a test to see if the body can maintain the glucose levels within a healthy range, even upon purposeful self-administration of glucose. In a diabetic patient, this standard quantity of oral glucose will go up greater than 11.1 millimoles per liter. Without the tolerance test, random blood glucose, if that is above 11.1 and the patient also shows diabetic symptoms, then the patient might be diagnosed as having diabetes. You might wonder where all those numbers came from, and usually it's from clinical experience over medical history, that these values are typically a threshold over which an individual becomes unwell. So diabetes can also be described as a spectrum. We all have insulin resistance to an extent, and our pancreatic beta cells are not always at the peak of their performance. Diabetic complications are classified into acute and chronic, and in acute complications there are diabetic ketoacidosis and HHS, or hyperglycemic hyperosmotic syndrome. Diabetic ketoacidosis is when the body breaks down fat too fast because the glucose cannot be used as the major source of fuel. Breaking down fat produces ketone bodies through beta oxidation, and It typically causes symptoms such as polyuria, polydipsia, and acetone breath. It's usually of a fruity scent, and also nausea, vomiting, and abdominal pain can arise from DKA. HHS, on the other hand, is an emergency typically observed in older population, and the cause is usually due to a very high osmolarity from high blood sugars. There is no ketone bodies or a significant alteration of blood acid levels, but this complication is from the body desperately trying to eliminate the high blood glucose through other means, and this time is through the kidneys. In HHS, fluids that are filtered but still contains abnormally high level of glucose is passed through the renal tubules. When this happens, the high osmolarity of the filtrate pulls in water from around the tubules. This results in polyuria, extracellular fluid volume contraction, and severe dehydration. Chronic complications of diabetes can include diabetic neuropathy, nephropathy, the diabetic foot, and diabetic retinopathy. Firstly, exploring diabetic neuropathy, there can be multiple patterns of numbness, especially at the periphery. In mononeuropathy multiplex, multiple nerve roots are affected simultaneously and can also even involve cranial palsies. So third, fourth, or sixth cranial nerves controlling the movements of the eye can malfunction. The neuropathy can also be paired with autonomic functions of the gastrointestinal, genitourinary, or the cardiac system, in such that the impairment is coupled with gastroparesis or abnormal blood pressure. The second on our list in chronic diabetic complications is diabetic nephropathy. As already explored in our chronic kidney disease chapter, diabetes with its high sugar level and high volume of blood can severely damage the filtration barrier in the glomerulus. Diabetic nephropathy follows a specific pattern of presentations where there is initially an increase in GFR in the pre-nephropathic stage. Then secondly, a slow increase in albuminuria, or the content of albumin in the urine. The third stage that comes after that is the decrease in estimated GFR to below 60 and albumin creatinine ratio of 2 milligrams per millimole or greater. And lastly, the complication becomes end-stage renal disease. So to review, first an increase in GFR, increase in albuminuria, then decrease in GFR to less than 60 and or albumin creatinine ratio of 2 or above. The unit is milligram per millimole. Diabetic nephropathy usually presents with a diabetes complication for over 5 years, and the signs are persistent albuminuria, bland urine, and slow progression. This complication does not exacerbate overnight. Another complication of long-term diabetes is the diabetic foot. This is one form of peripheral neuropathy affecting the lower extremity and can result in structural deformities. Diabetic foot can also result with diabetic foot ulcer, or DFU. The ulcers present in in the weight-bearing area within the foot, if it is neuropathic, and if it's ischemic or due to lack of blood flow, it can be at the lateral ankle or the distal digit as its characteristic locations. Lastly, Charcot foot or diabetic neuroarthropathy can also present with diabetic foot. And Charcot foot is basically a unilateral, warm, swollen red foot, especially with long diabetes mellitus and peripheral neuropathy. Charcot foot can have different stages, 0 through 3, and respectively its prodromal, development, coalescence, and reconstruction stages. The end stage is known as rocker bottom foot, where the bottom surface of the foot becomes uneven and difficult to stand on. The investigation is through X-ray or MRI, and the treatment can include offload of weight to surgery and cast and permanent custom shoes for lifestyle adjustment. The diabetic foot overall also has the wound classification by University of Texas, and it also ranges from 0 to 3, being epithelial to more dermal but no tendon or capsule or bone, 2, tendon or capsule, and finally bone or joint, respectively. Each of the stages can be further divided into stages A, B, C, and D. A is without either infection or ischemia, B is with infection, C is with ischemia, and D is for both. So in total, there would be 4 times 4 or 16 classifications for diabetic foot. The risks of developing this presentation include hyperglycemia, but also dyslipidemia, smoking, or hypertension. Not being able to feel the pedal pulses in both feet, and feeling asymmetrical temperature between the feet would be an indication for emergency. And therapies include pressure offloading, debridement, and antibodies in incidences of infection, or revascularization if it's ischemic. Also, as explained in the beginning, diabetes complication includes diabetic retinopathy. The microvasculature located at the retina can be damaged by altered viscosity and osmolar forces within the blood, leading to characteristic changes in the retina. We'll explore that later in the pathophysiology section. So the mainstay of diabetes treatment would be well-controlled blood sugar levels as well as blood pressure. Non-pharmacological choices in terms of lifestyle would be a very significant in terms of influences in the diabetes outcome. These non-pharmacological choices include regularly exercising, losing weight, and having a balanced diet, especially with low salt. There are a lot of different pharmacological options for diabetes treatment. Each of the options also present with extra advantages or disadvantages. Metformin, which can be in the form of biguanide or glumetza, affects the fat, muscle, and the liver. This medication, although the mechanism of action is largely unknown, reduces the hepatic glucose, as well as insulin resistance. This lowers the A1C by a whopping 1 to 1.5%, and as such is the go-to medication for diabetes control. However, anorexia, diarrhea, and in very rare cases lactic acidosis can occur from this medication. Alpha-glucosidase inhibitors like acarbose block the brush border alpha-glucosidase, which is disaccharidases, and therefore prevent peaking of glucose in the first place by preventing breakdown for absorption in the GI tract. This drug lowers A1C by around 0.5 to 0.75%. And its disadvantages include flatulence, diarrhea, or bloating. So if the patient also has GI disorders, it will be best to avoid this medication. Insulin secretagogues target the pancreas and stimulate the release of extra insulin. Both sulfonylurea and meglitinides have an unfortunate side effect of gaining weight. But in sulfonylurea, this can reduce A1C by 1 to 1.5%. The drug also has microvascular outcomes. That means preventing atherosclerosis and clot formation, and overall promoting the health of the microvasculature. However, it can promote kidney disease by lowering clearance of kidney functions, and may also raise the risk for liver disease. Meglitinides also reduce the A1C by 1 to 1.5%. And unlike sulfonylurea, it's okay to take this with renal impairments. However, this can actually promote hypoglycemia by secreting so much insulin. Incretin also exerts its effects on the pancreas, and there are two types. First, the GLP-1 agonist, which usually ends with tide, promotes glucose-dependent insulin release, and this reduces A1C by 1%, and this has the added benefit of weight loss and cardiovascular benefits. However, GLP-1 agonists can cause nausea and vomiting, as well as acute pancreatitis. If a patient has pre-existing episodes of hypoglycemia, a GLP-1 agonist can worsen that episode. Another form of incretins, DPP-4 inhibitors, ultimately work in a similar way with the GLP-1 agonist in that this medication inhibits the breakdown of GLP. The medication diminishes A1C by 0.5 to 0.7%. There is no weight loss associated with this medication, ending with gliptins. And it also has the disadvantage of upper respiratory tract infections and nasopharyngitis. Diabetes mainly affects the retina of the eye in terms of ophthalmic complications. To review the anatomy of the retina, let's target specific parts affected by diabetes, which are the vessels of the retina, blood-retinal barrier, and RNFL. The vessels of the retina can be seen on the fundus exam, branching out from the nasal optic disc, as you can see in the picture below. That's why pathology of diabetic retinopathy can be examined with a simple fundus exam. Because these vessels are in direct contact with the diabetic blood with high amounts of glucose and toxins from nephropathy, their permeability may change and sustain a lot of injuries. As such, dot plot hemorrhages, flame-shaped hemorrhages, as well as exudates and microaneurysms can be observed. The blood-retinal barrier, similar to the blood-brain barrier, is a tight conjoining of cells around the vasculature to prevent blood substances from entering the tissue of the retina. However, with diabetes, there is inflammation and breakdown of the blood-retinal barrier, and thus leakage of various substances into the retina can occur. Lastly, RNFL, or retinal nerve fiber layer, is an intricate network of nerve fibers from the optic nerve. Exploring the retinal layers a little bit more, the outer plexiform layer is a network of neuronal synapses in the retina. This layer houses the connections between horizontal cells and photoreceptors. Inner plexiform layer is also a network of synapses, this time between bipolar, amacrine, and ganglion cells. The internal limiting membrane interacts with the vitreous of the eye. Therefore, you can assume that the internal limiting membrane is the innermost layer of the retina itself. This layer is made up of collagen fibers, glycosaminoglycans, laminin, and fibronectin. The Bruch's membrane is the innermost layer of the choroid, which interacts with the outermost layer of the retina. This is basically a filter separating blood vessels from the retina. For diabetic patients whose age is below 30, there is a 50% chance of having diabetic retinopathy after 10 years from the time of diagnosis. After 30 years, the risk rises to 90%. However, for type 2 diabetes, 5% may already have diabetic retinopathy at the time of diagnosis. This is because, unlike type 1 diabetes, where the destruction of beta pancreatic cells are already evident, type 2 is concerned with systemic resistance to insulin, and its adverse effects are therefore made gradually apparent instead of right away. We have constructed a rather complex flowchart for the pathophysiology of diabetic retinopathy. Let's go through them step by step throughout the next few slides. And before we start, here are some of the pathology photos of the retina with various presentations of diabetic retinopathy. So, the high blood sugar levels in diabetes presentation can lead to non-proliferative diabetic retinopathy. In this stage, there are simple leakage and hemorrhages as well as microaneurysms. When this becomes severe and the blood vessels that are thoroughly injured are now unable to supply blood, there is a progression to proliferative diabetic retinopathy, where growth of new blood vessels, known as neovascularization, occurs. So here is a visualization of the progression we've talked about. The high blood sugar levels lead to NPDR, where the excess sugar adds branches to the retinal basement membrane, known as glycosylation branches, and endothelial cells of the vasculature proliferates. The retinopathy also breaks down the blood-retinal barrier, resulting in leakage of plasma and characteristic dot blot hemorrhages, as well as flame-shaped hemorrhages in larger vasculature. The breakdown of the barrier leading to lack of support for the vessels and the high pressure in diabetic vessels lead to outpouching of the vascular wall, known as microaneurysm. Eventually, the permeability becomes so much that retinal edema occurs, and in fundus exam, heart exudates with lipoprotein and lipid-filled macrophages trying to resolve this effect can be observed on the retina itself. The edema can cause retinal layer thickening as well as cystomacular edema, and the progression of vascular deformation leads to proliferative diabetic retinopathy. Increased viscosity in the blood due to raised sugar levels and red blood cell deformation leads to retinal capillary non-perfusion. Combined with vascular insufficiency in the previous slide about non-proliferative retinopathy, this exacerbates retinal hypoxia and ischemia. This results in formation of shunts and other intraretinal microvascular abnormalities like dilation, beading, segmentation, and in arterial cases, silver wiring and obliteration, as well as eventual neovascularization. This is dangerous because the newly formed vasculature is not as sustainable or resilient as the normal vasculature. The human eyes also anatomically and structurally do not support the new formation of these vasculature. Therefore, neovascular network can promote even more bleeding as they're connected to the circulatory system and has very poor wall support for the blood. And it can promote glaucoma and high intraocular pressure, especially when it invades the iris. Also, in proliferative diabetic retinopathy, there is a growth of fibrovascular membrane between the retina and the vitreous. This membrane that sits atop the internal limiting membrane can contract, and when it contracts, it can pull the retina along, causing retinal detachment. In diabetic retinopathy, there is also a lot of ischemia and infarcts, so a lot of tissue death resulting from that. So cotton wool spots are frequently seen. Diabetic retinopathy can present anywhere on the retina, if not all of them. And the degree of the presentation as well as the pathology can vary a lot, as explored in the previous slides. The actual symptoms that patients go through can actually be asymptomatic. This, in a way, can be more serious than having several symptoms to begin with, because there is no indication to evaluate the eye in earlier stages, and therefore, if spotted later, the safe window to initiate treatment and preserve vision of the patient may be missed. Therefore, we should all be vigilant about checking the back of the eye and referring properly for patients with diabetes. As diabetes progresses, patients may have decreased visual acuity and eventually blindness. Upon examination of the fundus, there are signs that can be spotted with diabetic retinopathy, as explored already. So thickened basement membranes, microaneurysms, and edema in the retina, as well as ischemia of some of the microvasculatures are prominent signs. Dot blot hemorrhages are mainly seen in diabetes, and cotton wool spots are indicative of infarcts. Neovascularization can occur in proliferative diabetic retinopathy. Macular edema can happen next as the final stage after proliferative. Venous beading and intraretinal microvascular abnormalities can be seen, and eventually retinal detachment is also possible. Similar presentation can indeed arise with different diseases. Hypertension can arise from diabetes, so hypertensive retinopathy has similar shapes of hemorrhages, such as flame-shaped hemorrhages. CRBO and BRVO can also present with microaneurysms and macular edema, and in rare cases, neovascularization. Ocular ischemic syndrome can also have macular edema and macular aneurysms, as well as cotton mole spots and neovascularization. However, these diseases also present with their own set of unique symptoms and signs and unique etiology. Yale's disease can also be presenting with a similar appearance as diabetic retinopathy. This is a bilateral and idiopathic and peripheral obliterative vasculopathy. Typically, adults in their 20s who are male are affected, and while there are microaneurysms, intraretinal hemorrhages, and also neovascularization, such disease also presents with perivascular sheathing and white sclerotic ghost vessels and vitreous hemorrhages. For any patient, it is very important to take a complete ophthalmic history, including the chief complaint and HPI, or the specific details of how the incident occurred and the settings of that incident. And with an ophthalmologist, the eye exam. This is composed of basic measurement of best corrected visual acuity, looking at pupillary reflexes in light and in the dark, and taking the pressure with the tonal pen after instilling freezing drops in the eyes. Other exams can include measuring the confrontational field to look for any visual field defects, looking for saccades, and checking if there's nystagmus, assessing the cardinal extraocular movements, and checking accommodative convergence. These do not have to be done all the time, except for visual acuity, pupils, and pressure. Depending on what the presentation of the patient is, you may choose as you see fit. Then the slit lamp exam is also very important and must be done on all patients. And with the equipment, you start at the lids and lashes, then work your way through the conjunctiva and the sclera, to the cornea, then the anterior chamber and the iris, then the lens and the anterior vitreous. Finally, especially in instances like diabetic retinopathy, you'll do a fundus exam after dilating the patient's pupils. After identifying all the pathology, we can also perform a gonioscopy and also order a series of investigations. This includes blood work with CBC and differentials, and fasting blood glucose, A1C, and blood urea nitrogen. If there's blood, if there's hemorrhages from the retina that's coming out to the vitreous, this may obscure the view of the fundus. In this case, a B scan can be warranted to rule out if there's any retinal detachments. Fluorescein angiogram can also show with high contrast any capillary non-perfusion, microaneurysms, macular edema, and neovascularization. Finally, the OCT performed can detect retinal thickness, cysts, subretinal fluids like the macular edema, and macular detachment. There are lots of criteria in diabetic retinopathy. For example, for determining if non-proliferative diabetic retinopathy is severe, we use a 4-2-2-1 rule. Basically, if there is diffuse intraretinal hemorrhages and microaneurysms in 4 quadrants, or venous beading in 2 quadrants, or ERMA in 1 quadrant, then NPDR can be determined as severe. Of course, take venous bleeding in more quadrants and ERMA in more quadrants would be even worse. High-risk categories of proliferative diabetic retinopathy includes neovascularization of the disc, and the extent of that neovascularization needs to be more than a quarter to 1/3 of the disc area, or the high risk can also be determined if there is neovascularization of the disc plus vitreous hemorrhage or preretinal hemorrhages. These are distinguished from intraretinal hemorrhages because the view of the vessels are obscured. The high-risk PDR is also determined if the neovascularization occurs elsewhere. Elsewhere is defined as more than one disc diameter away from the optic disc. So if the retina has MVE of area equivalent to half the optic disc area, and it accommodates, say, a vitreous hemorrhage or preretinal hemorrhage, this is also considered high-risk proliferative diabetic retinopathy. Lastly, clinically significant macular edema is very important to pay attention because macula constitutes the central vision. If there is retinal thickening less than 500 micrometers from the center of the fovea, or if there are hard exudates less than 500 micrometers from center of fovea with adjacent thickening, or if the retinal thickening is more than one disc area and is close, being less than one disc diameter of distance away from the center of fovea, the macular edema is considered clinically significant. The treatment of diabetic retinopathy is by treating the underlying cause, or the underlying diabetes. The tight control of blood glucose levels and blood pressure, maintaining them under 7% and 130/80 respectively, is the mainstay of the goals for diabetic treatment. And this also has direct benefits to the retina as well. Transpupillary laser photocoagulation, whether by argon green or krypton red laser, in a pan-retinal fashion can prevent future retinal detachments or progression of neovascularization. For clinically significant macular edema, the focal macular grid photocoagulation of size 50 to 100 micrometers, according to the ETDRS studies, has been effective, and anti-VEGF agents such as the Lucentis or bevacizumab, Alia or aflibercept can be an effective way to prevent neovascularization and macular edema. Second line is an intravitreal stereotherapy using 2 to 4 milligrams of triamcinolone acetonide, according to the drcr.net study. For PDR that has been determined high risk according to the criterion that we went through several slides ago, a scatter panretinal photocoagulation using burns that are one burn width apart from each other can be effective, and panretinal photocoagulation can also be performed with neovascularization of the iris or with glaucoma developed from neovascularization. If there is thorough retinal ischemia on fluorescein angiography, neovascularization of elsewhere, and severe non-proliferative diabetic retinopathy in the other eye. Pars plana vitrectomy by retinal specialist is indicated for non-clearing vitreous hemorrhages for 6 months. Early treatment and control of the A1C allows even better control of diabetic retinopathy. So the prognosis depends on how quickly the A1C and the blood pressure is controlled. The diabetic retinopathy can also be dormant for a long time, and focal laser photocoagulation can improve vision in 17%. Complications of diabetic retinopathy includes cataracts and neovascular glaucoma, as we've touched upon several times. Here is the link slide again to remind you of the connections between the ophthalmology and endocrinology as made by diabetic retinopathy. Here is a comprehensive summary flowchart to help your understanding. Here are all the sources of information that we've used to put together this PowerPoint. Thank you for watching this video.